Hello and welcome to the latest podcast in the UCM programme. Today I'm going to be talking about old drugs for a new virus, repurposing drugs for Covid-19 treatments. My name is Ken Mills and I'm a Professor of Experimental Haematology at the Patrick G. Johnson Centre for Cancer Research at Queen's University Belfast. I also spend a lot of time, including lockdown, on the Isle of Man, which has been a challenge maintaining the research and education programmes. Today I want to talk to you about some of our research we are undertaking as part of the global development of therapies for Covid-19. Research that is progressing despite the rest of the university research laboratories being closed. Perhaps I should start by saying about my background. I've undertaken research into blood cancer for many years, probably for over 35 years, although maybe I shouldn't mention that. I've worked in universities and research centres in Glasgow, Cardiff and Belfast. Blood cancers represent around 10% of all cancers and include diseases such as leukemia, lymphoma and myeloma. In February 2020, I spoke about my specific interest in acute myeloid leukemia at a #UCM Talks at the Nunnery, and I believe that talk is still available online on the UCM Research Events page. At this point, I should state that whilst I know lots about blood cancers, I actually know very little about viruses. But one of the benefits of working at a Russell Group university is that there's usually somebody who knows something about anything, and I'm fortunate that my colleague, Professor Alban Power, is an international expert on respiratory viruses. So how did this unlikely partnership manage to be awarded one of the first UKRI MRC research grants in March 2020? By combining my drug screening and cancer research experience with his virology expertise. Firstly, I need to explain a bit more about acute myeloid leukemia, or AML as I will refer to it. AML is a very aggressive disease which affects the maturation of blood cells and has a very poor survival rate of around 44% for over 5 years. But that falls to 12 to 18% in patients over the age of 65 years old. But as the median age at diagnosis is 65, that means that half the disease population has a very poor outcome. Part of that poor response is due to the disease. The molecular abnormalities that occur means it is inherently drug resistant. And that only gets worse as the disease evolves, and more mutational changes occur. However, the lack of response to the therapies is also due to the age of the patient. Chemotherapy is very effective in younger patients. That's because they can tolerate higher doses than the older population. So older people can only tolerate lower and therefore less effective doses. Our blood cancer research is focused on identifying therapies that are less toxic but as or if not more effective than standard of care. One way this might work is by using therapies that are already being used for other disease. We call this process drug repurposing or drug repositioning. These drugs might be used to treat diabetes, worm infections, dementia, heart disease, etc., etc. And we know they're safe to take as millions of people use them every day. But we also know that they have other effects that we could harness. These are not side effects that will be not good for the patient, but alternative ways that the body may respond to these agents. This also cuts down on development costs and the time for implementation for the therapy. Our leukemia studies on repurposing drugs is using a panel of over 700 of these approved drugs. We also know that as single agents, they would have poor or no effect on the cancers. But in combination, they may have additive or synergistic effects. However, if we're looking for pairs of drugs, then with 700 drugs, there are almost 250,000 pairs. This will have consequences in terms of resources and time to screen. We've developed and optimized, in combination with our computational biology colleagues, a method of using pools of 10 drugs. In this way, the algorithm assures that each pair is represented in at least one of these pools, and this reduces the number of pools we need to screen from 250,000 to around 5,000. The surprise is that the presence of pools of 10 drugs only results in the death of leukemia cells in around 4% of the cases. However, those 10 drugs can be then taken from the hit wells and are then deconvoluted to give 45 pairs which can be individually validated. We have so far identified 2 pairs and 3 triple combinations that we've been validated as having potential for treating childhood leukemia. So back to COVID-19. and our little friend SARS-CoV-2 to give this virus its Sunday name. There are two areas where new drugs and therapies can and are being developed. First is an impressive 115 vaccine candidates around the world currently being investigated, but it's still many months before a vaccine might be approved. The second approach is to look at repurposed drugs, similar to our approach for blood cancer. Vaccines will reduce the rate of infections, but will not stop them completely. SARS-CoV-2 is not like measles, where vaccines have virtually eliminated that disease, if sufficient people are immunized. SARS-CoV-2 is a respiratory virus and therefore is so more like influenza. And we know that a different mix of vaccine is needed each year as the genetic code of the influenza virus changes. Similarly with SARS-CoV-2, a recent study showed that there are found 1,300 slightly different SARS-CoV-2 viruses in the UK, which could be mapped back to their country of origin. Surprisingly too, less than 1% of these viruses were from the Chinese strain, the majority coming from Spain, Italy or France. Although some studies have suggested an interesting association between the severity of COVID-2 in a country and how many of the population were vaccinated with BCG, the BCG vaccine apparently reduces the damage caused by COVID-19, whilst the MMR vaccine could also help to drive a protective immune response against SARS-CoV-2. People still become infected with SARS-CoV-2, and some will become ill and some will become very ill. And it's not the infection itself that causes illness and death in COVID-19, it's the inflammatory reaction. Inflammatory responses affect the body in many ways, increasing blood clots which make the heart work harder and reducing oxygen to vital tissues such as kidneys, which can go into failure. Some patients are hit by a cytokine storm. This is the body's inflammatory response, which is meant to help clear out infected cells. However, it goes into overdrive and starts attacking healthy tissues and organs even after the infection has been resolved. So these effects of COVID-19 will need a completely different approach for their treatment. To identify potential therapies, we've taken the approach of using repurposed therapeutic agents that could reduce the inflammatory response and thus reducing the severity of the disease. We have adapted the approach we're using in our cancer studies and are initially using a small library of drugs comprised of a known antiviral and anti-inflammatory agents. Then we will roll out the research program and use our full library of over 700 agents in a combination study. Our preliminary data is encouraging as we've had several hits, but these need testing and repeating on other SARS-CoV-2 strains and then on models of human airways. Some of these models are air-liquid interface or ALI cultures of human primary airway epithelial cells. The human airway epithelial is the first line of defense against respiratory viruses, and so by using these models we have a bit more of a realistic manner by which we can validate and test our drug combinations. Some of these hits are anti-inflammatory and some are antiviral agents, but some of the agents are not either of them, and some are not even therapies you would consider having any effect on COVID-19, but they are effective in combination. Cancer and viruses have something in common. They both evolve and change in molecular makeup with time. So although we're at an early stage in our research, it's an excellent example of how we can use our different expertise and techniques in an innovative manner to respond to the global challenge of COVID-19. Thank you for listening.